Do y'all mind if I just sit and do like table discussion?
Perfect.
All right, well, we are ready now. You are. Thank you so much for coming. So we have some of our staff members here and some of our instructors.
Okay.
And then we're taping it so we can show our other instructors as well. So.
All right, well, hi everyone. I am Mary Wondrop. I'm the Director of Epilepsy Services for Abilities Network. Abilities Network is a nonprofit agency that has multiple services underneath of it. One of those divisions, one of those services is the Epilepsy Foundation of the Chesapeake region. So we are associated with the National Epilepsy Foundation, and the National has affiliates throughout the country. Pretty much not quite in every state. Some states have more, like Texas, and some states don't have one, like Wyoming. So, I guess depends on the population. But we're the affiliate that covers Maryland. So we are associated with the National Epilepsy Foundation, and a lot of our information that we provide comes from professional advisory boards that come from the National Epilepsy Foundation with information that they put together and gather. But being in Maryland, we have the advantage, especially in Baltimore, of having Hopkins and University of Maryland and even Sinai, if any of you are familiar with Sinai, has a brain and spine institute. So we have a lot of very well-known established medical systems here that have epilepsy centers and clinics. So we have specialists, and they sit on our local advisory board, which is nice. Hi. That's okay. So you have the same thing. So my name's Mary.
I'm Erin.
Hi, nice to meet you. So thank you for having me. I know this was very important to Stephanie, the mother of one of the young men that does the riding, uses your riding services here, that she wanted to have epilepsy training done. And as far as my feelings being from the Epilepsy Foundation and knowing how prevalent seizures are, I find it important for wherever you work, whatever you do, it is important to know, because you could be working in a 7-Eleven and somebody could have a seizure. You could be out on a field or a sports field or anywhere. So it's always nice to know what seizures are, what they look like, to recognize that is what's going on with someone, and then know the proper first aid to do to take care of and help that person. They don't last long, so usually by the time emergency help comes, the seizure's over. So that's why it's important for whoever's around when it occurs, just to know the proper way to handle it. Okay, so I just have a quick review about epilepsy and seizures. If you have any questions, please interrupt me, anything that you want to bring up, discuss. I also brought a short film that shows you samples of seizures, and that's why I like to bring the film so you actually see some of the seizures. And it's a little quick review of what we're going to do too. But you'll see some samples of the different kinds of seizures we're going to talk about, so you can recognize them. So you all should have one of the handouts. Okay. All right. So just to start, I've said epilepsy and I've said seizures. So how do they relate with each other? Well, epilepsy is this disorder characterized by recurring seizures. Sometimes it's called seizure disorder. Some people will not put epilepsy down. If you're asking for diagnosis, they'll say seizure disorder. It is one and the same thing. Some people will argue and say, no, it's not. But epilepsy is kind of this general big term that takes up many, many different conditions that all cause people to have recurrent unprovoked seizures. So many different conditions can cause people to have that, and they all fall under that category of epilepsy. So epilepsy is kind of easy. It's actually the epilepsias. It's like more of a plural kind of thing. So what's a seizure? Well, a seizure is a brief temporary disturbance in the electrical activity of the brain. So when we say seizure, we're picturing what's happened to the person. That's a seizure. But what's actually going on? Why are they doing this? It's because the electrical activity in the brain is not functioning the way it should be. It is this disturbance that's happening. It's actually an excessive amount of electrical activity is occurring. And we'll look at that a little bit deeper. So that's pretty much kind of the terminology, general terms and definitions for that, pretty self-explanatory. Okay, so when I said epilepsy, sorry, I feel like I got it's a tickle, you know, you get the tickle. Okay, so who has epilepsy? Well, it actually is more prevalent than people think. About 2.3 million Americans have epilepsy. And there's about 50% of the people with epilepsy develop seizures before the age of 25. So it's rather prevalent in the younger generation. The next generation that seems to show a lot of seizure activity is elderly. We're seeing more and more seizures occurring in the elderly. So that's a growing population as well. So it's spread out. You can have it at any age, but it just seems to be a little more prevalent under age of 25 or in the elderly. Okay, now that is who have epilepsy. And epilepsy is you have to have 2 or more, it has to be recurrent unprovoked seizures. But many people can have a seizure. And that actually is a higher number. 1 out of 10 people, so 10% of the population, will have a seizure at some point in their life. So even if you may be working with somebody that don't have epilepsy, something could occur that causes them to have a seizure. So it's always good to know you would handle the first aid the same, whether or not it was epilepsy, or sometimes people that have diabetes and their blood sugar levels are not off. If they have excess in insulin, then they can have a seizure from that. Well, it's not an epileptic seizure, but you would treat the first aid the same with the diabetes. Now, of course, then you would also look at making sure they're getting the insulin that they would need. You would take it a step farther with diabetes, but as far as keeping them safe during the seizure, it would be the same procedures. And we're going to talk about what you would do with that. Okay. So that's where, when I said, it is rather prevalent. Okay. So, well, what causes all this epilepsy? All these people have it. Why do so many people have it? For about 70% of the people that have epilepsy, they have one of the syndromes of epilepsy. There really is no clear known cause as to why they have it. They believe it's just within their genetic makeup that they're prone to seizures. But for about 30%, and this number is slightly changing because our technology is getting better and they're able to do more studies and things. But the 30% that they know why, it can come from things such as head trauma. Anything that affects the brain can cause a person to develop seizures, because seizures occur when the brain is not functioning the way it should with that electrical activity. So head trauma is really the #1 known cause. When we're looking at that 30% that we know why, head trauma is the #1 known cause. And I would imagine, I think I heard you all work with veterans as well, and you may be dealing with people that have the traumatic brain injury, that type of thing, that can present in seizures at some point. The other things could be if people have any kind of sickness, infections that have gotten into the brain. Any lead poisoning can affect the brain. So really anything that can affect the brain. It's kind of interesting. You don't really think about encephalitis that much as being a seizure trigger or causing seizures, but we have about 4 people within our support group it's all developed. Their seizures all developed through having encephalitis at some point that then caused damage to the brain, and at different ages. Like one of them had it at age 2, another one when she was about 12, 2 in their early 20s. It can happen at any time, and which is really kind of a scary thing and also very hard. Here you have a person, both of the ones in their early 20s who graduated from college, both of them were actually working for the government and contracting, like NSA for one and as a contractor, and another one, and now they developed the sickness, ended up in a coma, came to, and now have seizures, and it has really altered their life completely. So it can be, rather devastating for some people. So anyway, these are the different things that they know are causes. But like I said, the majority of the cause, it's unknown. We call it idiopathic epilepsy, and it is something that for some reason some people just develop seizures. They can't pinpoint exactly why. They can't do a MRI on the brain or brain scan and see any kind of damage, or they know in the history any kind of damage that has occurred. For some of those individuals, they can outgrow them. They can go away over time. Not everybody, but for some they can. So, I thought the light just went a little brighter behind it. Sure.
You said it doesn't show on an MRI that, like where the specific damage is and what's done. Really?
Not for everyone that has epilepsy, no. Some, if you looked at a brain scan, some of their brains can look completely normal. Now, if they're having a seizure, they will, and the tool they use for diagnosis is an EEG, where they glue the plugs all over the head and they look at the electrical activity that's occurring. And if there's increased electrical activity, that's showing seizure. I mean, we're all going to have some. We're all going to have some electrical activity. Obviously, it makes our body work. We don't want to be, sitting here like stones with nothing happening. But if a person is having a seizure, you will see it's little lines. I don't have an EEG in this one. I have many different trainings. I tried to come up with the one that was kind of
like a earthquake or something.
Yeah, when you see the lines. It's similar to like an EKG that takes the heartbeat, but that's a little more even, where the brain waves aren't quite as even, and it depends upon where on the brain the EEG, the plugs are, because they put them all over the brain. The brain is divided where it does many different functions. Will be how involved the electrical activity is. So if a person is having a seizure, instead of it just being kind of like this jagged, it might be like, and then go on when you see the seizures. Yeah, because it's that excessive electrical activity that's occurred.
So it would be excessive, it wouldn't be, that would be something else. I didn't know.
Yeah, and it's kind of interesting because you're seeing it's excessive amount of it's more electrical activity that's occurring. But if you look at a person that has a seizure, depending on what kind, like an absent seizure, which is where the person just blanks and stares like they're daydreaming, it looks as if it should be flat. I mean, it looks like it should be nothing because they seem to just be gone. But it's actually, an excessive amount. So now, I talked about the amount of people that have it. When we look at that overall number, it was the about 2.3 million Americans have epilepsy. In a recent study, they broke it down some more when the Institutes of Medicine held a committee in 2012. And they determined about 1 in 26 people will develop epilepsy at some point in their life. So the difference being, when I gave you that flat out number, about 2.3 million Americans, that would be at any one given time. If we took a snapshot of the United States and counted how many people had epilepsy right at that moment, it would be about 1 out of 100, and that's where they come with that 2.3. It's about that percentage, 100%, 1% of the population. But over a person's lifetime, because as I said, some people may develop epilepsy, they'll have it for a while and then outgrow it. Or they develop it later in life. That's more the 1 in 26 number will develop it at some point in their life. Okay, and the risk is higher for certain individuals, and that's with different medical conditions. So with the population you're all dealing with, you're dealing with people that have different medical conditions and different needs to need the therapeutic riding, so you have a population that may be at higher risk to have seizures. And that would be individuals with intellectual disability have a 10% higher risk. Then also autism have a 10% higher risk to also have seizures. Cerebral palsy, 1 in 3 children with cerebral palsy also have seizures. Now if you add cerebral palsy and intellectual disability together, with here this poor child has both these, 50% of them are going to have seizures, so just throw that on top of them too. It's just really hard. 10% of people with Alzheimer's disease, and this is where we look at that elderly population that's growing, develop seizures. And then the number 1 cause in elderly is strokes. people that have strokes, of course, that's going to damage the brain. 22% of them normally go on to have seizures as well. So the next slide is the brain is the source of epilepsy, and we really kind of have already discussed that, and that's talking about that what it actually is when that excessive amount of electrical activity happens in the brain. It's a misfiring of those electrical currents is what causes the seizure to occur. So it can look very different because, as I said, the brain is divided up into parts. I mean, now if you open the brain, you're not going to see it in little compartments. It's just the way it's made. Different parts of the brain control different things that we do. So depending on where in the brain this malfunction is occurring is what seizures are going to look like. So since there's so many different ways that seizures can present, they have determined a seizure classification chart. And that's how you have names of different kinds of seizures. So out of all the different seizures, they're divided into 2 categories. And it's pretty simple to follow. The one category is a generalized seizure. Generalized means that electrical activity is taking over the whole brain. It's affecting the whole brain. Partial seizure is what you all have on your sheet. Just within the last year or so, they decided to change that name. They keep changing names on us. They decided to change that name and call them focal seizures. It's the same thing, F-O-C-A-L. I still like to think of it as partial though, because to me partial is easier to understand. Partial means it's only affecting part of the brain. The electrical activity malfunction is only happening in part of the brain. So one of the biggest difference in these 2 seizures are, if it's a generalized seizure, the whole brain's affected, or this person going to be able to be conscious. If the whole brain's affected, they'll be unconscious. Partial seizures, they can still be conscious because the whole brain is not affected. Now, depending upon how involved these partial seizures are, they may have altered consciousness, or we have a simple partial seizure that they still may be completely alert, and the only thing the symptom they're getting from the seizure might be they're smelling something different than the rest of us in the room. They're having a seizure in the area that controls smell, and it might be they're smelling gasoline. The rest of us don't smell it, but they would be having this sensation, and it's because they're having a little seizure that would cause them to do that. And it could be, anything depending on where in the brain the little seizures happen. It might be that they, this part that controls movement, this hand, is having a seizure, so their hand might be clenching. They're still alert, they can still talk to you, but they're not making this do it, it's doing it on its own. They couldn't make it stop because it'd be a little seizure occurring now. So, now out of the 2 different categories, they divide them then, break them down even farther into different kinds of seizures. And there's over 20 different kinds of seizures. I'm not going to talk about all 20 kinds, so we're not going to be here all day. Okay, so from the partial seizures, I've already just mentioned the simple, that it's, can just one little part of the brain that can happen. Consciousness is not impaired. They can still, be interacting, communicating. And then the other kind of partial seizures I want to mention is complex partial, which is more involved. Hence the word complex is where I say our vocabulary is pretty easy to follow. So with a complex partial seizure, it will be, the person may even look like they're going into kind of like a daze, a sleepwalk. Their consciousness is altered. So they could be looking at you, but if you're talking to them, it will be as if they're really not picking up what you're saying. They're not able to communicate well, respond. They can still be wandering around. They may, a lot of times they make some kind of funny chewing, lip smacking motion, and they will have what we call a automatism, which is a repetitive motion. It could be maybe picking at their clothing or just kind of patting, or they may even look like they're picking at something in there, nothing's there, but they're just making this repetitive motion that doesn't seem to have a purpose. One of the young women that used to work with us, she had partial seizures, and she'd be in the office, she'd be talking to her, and if she went into seizures, all of a sudden Sometimes her seizures would just kind of stay kind of simple, where she would all of a sudden kind of stop and look up and like up off to the side. You would just see this strange kind, and then that would be it. Other times they would be more involved, and she'd kind of look up to the side, and her arm would come up, and she'd do a little twist with her hand and come down. And then every once in a while she'd even get like a little twirl, like a little ballerina twirl thing that she would do. And she said she didn't know what she was doing she wasn't aware of what she was doing during the seizure, but when people told her what she looked like, her response was, well, at least I'm graceful. At least I'm not doing something that looks, really goofy. So, yeah, it can be, different things for different people, but whatever they do tends to be stereotypical to them, that will be what they do each time they seize. And that's one of the good kind of things to be aware of, because if you have an individual you're working with that has those kind of seizures, you know this is going to happen. And they're doing the exact same thing they usually do, and the seizure ends within our general rule is 5 minutes. Everything's good, they're reoriented back and everything's fine. But if they go into this and you see behaviors that are not typical to them, then yeah, it can be a problem. Okay. So the other thing that people that have complex partial seizures will do is they'll resist restraint. And what's going on is they're altered. Their mind, their consciousness is altered. They're not really thinking clearly. So if you see somebody and they start wandering, if you go and grab at them, they may feel this fear of your being aggressive to them because they're not thinking, they're not comprehending. So they may then kind of fight back as if protecting themselves, but they're in this state, so it doesn't always look real clear. So that can be an issue. We do a training for police officers because we find a lot of times when there is an issue that a seizure has not been handled properly within the law enforcement, it is normally this type of seizure. And it's usually because there was some kind of restraint, the person appeared to be aggressive, so then the police officer became aggressive, and it became an issue with that. So one of the first things we say for first aid for complex partial seizures, do not restrain them. Now, you don't want to let them just like wander out into the street or into an area that could be dangerous. So we suggest you just gently guide them. If you just kind of stand in between them and whatever, they very rarely will come after you. If you're just in a gentle kind of way, blocking them. If it's in an interior, you can shut doors to keep them in one area. They very rarely will become aggressive to go through things unless for some reason they're provoked to be. You want to gently guide them away from danger, like I said, not let them wander out into the street. I guess here you won't let them wander into the middle of all the horses if they're walking around. Then you want to just speak calmly, reassuringly to them, we're here, you okay, you okay, Sam, we're here. And then you don't need to get loud, even though it looks like they're not hearing you, it looks like they're not responding. It's not their hearing, that's the problem. It's that the brain is not comprehending and allowing them to respond back. Some individuals that have this say they do hear what's going on, but they just can't make themselves respond back. They can't put it together to make that response come. Yeah. And then of course, you don't want to leave them unattended. You want to just walk away from them. You want to stay with them, keep them. So the key is keeping them safe. You keep them as safe as possible. It's pretty much common sense with this type of seizure. Okay, when they do the seizure ends, you just kind of reorient them back. You ask them their name, just kind of make sure that they are aware of where they are and that they have been able to. The consciousness has come back where they are on key with what's going on around them. Okay. All right, so generalized seizures affect how much of the brain? I'm waking you up, I know this is hard after lunch. The whole brain. Okay, so after, a generalized seizure means they're going to have loss of consciousness. And I already mentioned the one kind of seizure we call absent seizure. It used to be called petit mal seizure. Sometimes you'll still hear that terminology. Absent seizure is when the person just blanks for a couple seconds, very quick. They just look like they're kind of daydreaming for a couple seconds. Difference being nothing is there. A daydream, they're thinking about something. An absent seizure, it's blank, nothing. It's as if like somebody just turned the light off. They're gone. And then they come back again. Usually rather quick. Tonic-clonic seizure. This is what we call the stereotypical seizure. Old name for it is grand mal seizure. A lot of people think of it in that terminology still. That's where I say they keep on changing names on us. Now, tonic-clonic's been around for a while, but you still hear it referred to as grand mal a lot. In this seizure, this is what most people picture when you think of a seizure. And it's really because when the person's having this kind of seizure, it's obvious a seizure is happening. Tonic-clonic is a phases. Excuse me, phases of the seizure. I spent the week Thanksgiving in Michigan with my daughter, and I think I came back with a Michigan cold, so I apologize here. The tonic phase is the beginning of the seizure, and it's stiff. Actually, tonic is that the body stiffens. They get very stiff. They may make some kind of cry, grunt, or groan. And then their heart rate decreases. Their pupils tend to dilate, and their breathing ceases to be normal, all that. And then they go into the clonic phase, which is the bilateral jerking. That's the clonic, is the jerking. When this is going on, they may be making snoring, gasping sounds. They may have a lot of saliva that builds up in their mouth. People say they foamed at the mouth. Well, it's just the saliva that's building up, and with all the movement and the oxygen all blending, it looks foamy. Sometimes it might be a little bloody because they can bite the inside of their lip or their tongue when they go for that tonic phase. Sometimes the jaw clamps shut, and then they might have bitten some, so you might have a little blood mixed in with it. And then that lasts for about 2 to 5 minutes. 5 minutes is a very long time frame. It usually ends within about 2 minutes. The tonic phase can go up to a minute, but that's usually a lot quicker, maybe about 15 seconds to 30 minutes, and then they go into the bilateral jerking. And then you see the jerking slowly subside, they relax, and then they go into what we call the postictal state, and that's where they're recovering from the seizure. When we look at timing of a seizure, postictal state is not part of the timing. You're really timing the seizure, because postictal can be really prolonged for many people, but it doesn't mean like they're having a 30-minute seizure if it takes that long. If the body has relaxed and you see them evenly breathing, and they'll slowly regain consciousness, and they're going to be groggy for a little while after the seizure's over, and normally need to sleep. They're going to be tired and need to sleep. I would imagine your policy is if they go into this kind of seizure, you're calling 911. And but as I said, it's not even going to last 5 minutes most of the time. So you're going to be the one dealing with this before 911 even gets here, before the emergencies people even get here. Okay, so then they would take over from there, to determine what would need to be done. Okay, so any questions about any of them? And like I said, I'm going to show you a quick film. So for the first aid for the tonic-clonic seizure is stay calm. Obviously, it's very uncomfortable. When I said the time frame, they usually only last about 2.5, maybe 3 minutes. But if you're watching a person have one of these, it feels like it's a lot longer. So has anybody ever experienced anyone having this kind of seizure? And it's a very uncomfortable thing to watch, and it feels like it's going on for quite a while. So one of the things we say is track time and really try to make a note of time. Don't guess. Yeah, that had to be, so many minutes. Like really, if you have a watch or cell phone or whatever, check the time when you notice the seizure starting, just so you can have an idea of the time. You don't want to restrain the person for this. Now, they're not going to get up and walk around like the complex partial, but when we say restrain, some people see a person shaking and they'll feel like, oh, you know, they need to hold them, keep them. That's what the brain is telling the body to do. This electrical malfunction is sending these messages to the body, making the body do these actions. So you have to let this occur. If you don't, you could cause damage with muscle restraint, or you could get hurt because their body's going. But you do want to make them as comfortable as possible. So you want to protect their head. If they're on pavement or ground, put something soft under their head. We suggest you don't use your hands. Try to use a jacket or whatever you'd have, soft you could stick under their head. Remove glasses. Loosen any tight neckwear that they may be wearing, or anything else that they may have on, that could be cutting off their airways. There was an incident in Michigan where a young man had earphones with an iPod on, and the cord had wrapped around his neck. So anything, you're conscious of anything that could be cutting off there. And then you turn the person on their side. Any ideas why we do that?
So they don't aspirate on them.
Yeah, keep them from choking. So and all the saliva, so they don't they breathe it in, so they don't aspirate, so they don't choke. Sometimes people may vomit during a seizure, so that will drain out. The saliva drains out. Then just if you don't know the person, of course you check to see if there's an epilepsy or seizure ID. Of course, in your situation, you would be calling 911 anyway. That's because a person that has epilepsy, that has this kind of seizure, and the seizure ends and they slowly regain consciousness, they don't need to go to the emergency room every time. There's really nothing the emergency room can do for them. If their seizures ended, they're fine. They'll be put in there and then sent home. So, that is, policy on when I go into schools, wherever, we follow whatever your policies are. Okay, and then of course you wouldn't walk away from them until you knew they were fully alert and conscious and aware, and help reorient them. There was an issue, this is years ago, I don't know if any of you remember this one, probably about 10 or more years ago, that there was a gentleman in New York that had a seizure on a subway platform, fell down into the tracks. He apparently had a seizure, and the gentleman went to help him, and they thought he was finished, but he stood up and he was still within seizure activity. Fell down onto the tracks, and one of the people on the side jumped down. Subway was coming and smashed him down into the track. Two of them laid on the track, so the train just went over top of him, and he wasn't hurt. It was on the news, for a while and all this happened. But it was one of these, he had the seizure and then, got up, was still disoriented and still kind of in that seizure activity. So that's where it was like, you make sure they are definitely reoriented. But the guy was a hero that saved him. That's very brave as far as I'm concerned to be, yeah. You would stay with them. And then, our rule is 5 minutes general, but each individual that has epilepsy, if they're in schools, if they're in a program, they should have a seizure action plan with them. Here you have the seizure action plan, you would follow whatever the time frame is, because some individuals may have a pattern that every time they seize, they don't come out of it right away. So they may be, you call for emergency help all the time because they're going to need emergency medication. Or other ones know their seizures are a little longer and they don't want to, after 5 minutes give them till 6. So it would be whatever the seizure action plan they would have, you would follow.
I was going to say, one thing that's maybe a little different here than in a school is that, often the parent or guardian would be here. So I don't know, is our policy to call after 5 minutes? Do you defer to the parent in that situation, or?
We probably would,
Yeah.
Yeah, because our policy's for them to stay here.
Okay,
Yeah.
okay.
We
And
don't
then-
have a written policy to call 911
After,
after, a certain amount of time.
Okay.
Something we can certainly consider, but.
and then if the person were wearing their helmet, you would say, obviously not if they're on the horse, but once they're on the ground, you would take the helmet off.
If it looks like it was
Yeah.
cutting off airway.
Yeah.
Yeah, I mean, it'd be good they had a helmet on
Yeah,
here.
well, that's the thing, yeah.
Because,
Like,
something, we would like some people with epilepsy to wear a helmet more than, but it's
Yeah.
hard, and we understand, it's a stigmatizing
Yeah.
thing, it's very hard, but at least here, when people are wearing helmets, they're all part of the crowd, so that's
Yeah.
a nice thing, yeah. Yeah, but if the strap is, you wouldn't be so concerned about this part, it would be more if the strap was cutting
looking
off.
tight, yeah, okay.
Mhm.
Thank you.
So, any other questions? Okay. There are things you do not do when a person's having a seizure, and this is an old wives' tale, and some of you probably have heard it. Put something in the person's mouth. I don't know, we have a younger group.
I heard that when I was a kid.
I feel old because I remember that was definitely something. But you don't put anything in the person's mouth. They thought that was helping the person, because of the choking, they went to swallow their tongue, but they found out it was actually more dangerous. Some people even put fingers, like they would try to grab the tongue, and then their fingers would get bit because the jaw clamps down. So we highly suggest nothing in the person's mouth. You don't want to hold them down or restrain them, as I said. You don't want to attempt to give them any kind of oral medication, it's like, oh, they need their medicine. You don't try to, get that in their mouth. Now, in case you have parents here that do have emergency meds with them, which I'm not expecting any of you, but if you see a parent and they are having, there is some, they do prescribe some oils that they do in like a bottle where it drips down in between the lip and the gosh, my mind, right, the jaw, the gum, thank you. My mind's like, the thing right there, the teeth are in. Yeah, the gum, and that is like an emergency medication that can be used. There is also an emergency medication called Diastat, which is a rectal suppository that people may have. Now, I'm not, like I said, I'm not expecting you all do this, but if you would happen to see a parent that has this is something that is there. It's not like, whoa, what are they doing? And they now have a nasal spray as well. Nasal spray isn't FDA approved yet. Some